All right. Hello, everyone. This is a wound care presentation for correctional nurses. It was developed for correctional nurses based on the Federal Bureau of Prisons Clinical Practice Guidelines. And then I also used a wound care textbook. My name is Joseph May. I'm credentialed in wound care, ostomy care, continence, and foot care. I'm a board certified national health disaster professional and certified correctional health professional -RN. I'm full-time wound care specialist. So my goal is for you to, regardless of your practice, if you're an administrator or a staff nurse, get some gems that can impact your practice. We'll do the disclaimer thing. I have no financial relationships to disclose or a conflict of interest, and my opinions are my own and do not reflect the agency for which I work or any government agency. There was no commercial support. So the biggest part of, we're going to spend a little while on this slide. The biggest part of wound for nursing, for staff nurses especially, is the assessment. And this is because when things are going wrong, you need to be able to communicate why you have a bad feeling. It's great that nurses have intuition, but you need to be able to communicate to the provider what the problem is, and documentation is extremely important for legal purposes. Without, this isn't a legal presentation, but I think it's safe to say it's common knowledge that big areas for lawsuits in corrections are loss of function, loss of wage earning potential, and pain and suffering. So we'll talk about some documentation. So just going down the slide, the standard for wound care measurement is location times width times depth, and location is always first. But even though that's the standard in my own documentation, I always label them length, width, depth. Location is 6 to 12 o'clock on a clock face. And so we always document the wound bed, and what I mean by that is a percentage of color. So I may say it's 100% red. Well, why is that important? Well, if you compare documentation, the previous dressing change, it goes from 100% red to 80% red and 20% white. You're documenting increase or decrease of slough, eschar. Sometimes wound beds can get dark for decreased blood flow or critical colonization of bacteria. Don't need to get in the weeds on the science. But the surrounding skin, this gets into infection. Here's a little gem for you to put in your pockets, is you can have inflammation without infection, but you can't have infection without inflammation. So basically you're looking for signs of inflammation, which is redness, swelling, induration, which is firmness to touch, and tenderness. Also, wounds would have increased drainage. So the pain's real important to document. I usually document, I used to document tolerated well as a staff nurse, but as a wound care certified nurse, now I document denied pain before, during, and after treatment. And then if there is pain, sometimes, where I work, if you document a patient has pain, this triggers a pain assessment window. And I will put non-pharmacological interventions such as distraction, discussion, encourage patient to engage in distraction, discussion, and sign up for sick call if it worsens. So, and then barriers to healing. On my template, I have a template for all my initial visits. Barriers to healing I address. So these could be must walk to chow hall every day, which is a problem if they need to walk less to promote healing, that sort of thing. Conditions of correctional environment. Other things that you should include on your assessment, this is the longest slide. Other things for the assessment for a nurse specifically, seems like common sense, but it's worth mentioning. If it's a pressure injury in a bed and they're sitting in stool or urine, you should note that, right? If they need to, if they have a wound on their foot and they're walking around without shoes, you should note that. If they're staying up all night and not getting any sleep, probably note things that would affect the healing, just as part of good documentation. Other things would be allergies, medications, past medical, surgical, and mental health history, cognition changes, and ability to perform activities of daily living. Wounds, especially on extremities, or if you're doing a leg wrap, do capillary refill, do a pulse, document it. for more, nurses generally implement a dressing change ordered by a provider, but that's one of the things I love about nursing is even though we have this scope of practice, we can be so impactful by educating ourselves. So if you can recognize signs of venous insufficiency or arterial insufficiency by skin discoloration or lack of hair or pitting edema, that's just one more tool for your toolbox. Obviously temperature, and hopefully you don't have to get a Doppler to find pulses. So we're going to quickly go over the phases of healing. They're important to know just because wounds are a puzzle, and if you to understand why a wound isn't healing, you kind of need to know the puzzle pieces. So hemostasis is just controlling the bleeding. The small vessels constrict and the clotting cascade is activated. The platelets release growth factors and cytokines, other cellular mediators. It immediately starts the inflammation phase, and we're going to talk about inflammation, which is the second phase of healing. And the platelet fibrin actually is the basis for extracellular matrix, which becomes the granulation tissue. So it sounds pretty sciencey, but the inflammation phase, this is all about the body's own debridement. So if there's dead tissue, slough, white blood cells that have done their job, they need liquefied and get out of the wound so healing can occur. It controls infection, autolytic debridement. Neutrophils destroy bacteria with enzymes. Macrophages engulf necrotic tissue and bacteria and other cells that have served their purpose. The proliferative phase is the healing. And before I talk about this, it's important to note that the phases of healing can overlap. So one of the reasons a chronic wound will stall is that it's stuck in the inflammation phase. And typically it's stuck in the inflammation phase because of either a disease process, like chronic venous insufficiency or congestive heart failure, or the etiology, the cause of the wound, the mechanism of injury has not been mitigated and relieved. So proliferation is, let's divide it into full thickness wounds and partial thickness wounds. In full thickness wounds, it's proteins and collagen forming the extracellular matrix, which looks like the dimpled pink granulation tissue in a wound bed. The initial granulation tissue, and even like brand new skin also, I always tell the patients that just think of it as tissue paper. It is so fragile. When it's brand new, it only has 15% of the tensile strength as normal tissue. So it can devolve super easily in just a few hours of pressure or whatever the mechanism of injury is. In partial thickness wounds, they go through all the same phases of granulation tissue and reepithelialization from the margins, like the mitosis of the cells. And in partial thickness wounds, all that happens, but the dermis and epidermis completely regenerate. So partial thickness means it just doesn't go beneath the basement membrane of the skin. And the cool thing about those like, shallow wound burns, shallow skin tears, is they completely regenerate without a scar. That's what that means. So remodeling or maturation is, like I said, just the tissue becomes stronger and stronger, and it can last up to 2 years. But even when the tissue is as strong as it's going to be, it's only going to be 80% as strong as the original tissue. So chronic wounds, typically that's the majority of my consults. It's crucially important that I identify the etiology, which we'll kind of get into a little bit. And by the way, like if you crack open a wound care book, at least for nursing wound care certifications, each etiology typically has its own chapter. So, which is useful that it's divided up that way, because you can identify the etiology and look up the book to educate yourself more. So as far as intrinsic and extrinsic, these are very intuitive. Intrinsic is like the person's health, and extrinsic is things maybe still in their control, but like part of the environment. And that goes back to your documentation. You should document some things, especially if the patient's, being quote unquote non-compliant. I know that's not necessarily a word that's like to use sometimes, but if they're not following medical advice or they could do better, document education, reinforce to wear footwear while in a wheelchair. Some considerations for intrinsic, like lower extremity vascular disease. If once a patient starts compression stockings, you just tell them that they're going to have compression stockings for life. Like they should just know that going into it. And then lower extremity artery disease. If you see a patient that has, very pale, no hair on their legs, and reduced, if you already know they have artery perfusion issues and they're walking around barefoot, that's no good, because lower extremity artery disease, they need to protect their feet from trauma, cold, and moisture, wear appropriate footwear. Extrinsic factors would be, support services, management of wound exudate, management of incontinence. So these, I took pictures of actual products in our facility. Dressing products, they can be bewildering, but when in doubt, just put gauze and tape on it. You can't go wrong. Wounds are a little bit like Goldilocks. They want to be just right, not too wet, not too dry. So broadly speaking, you have wound dressings that can either absorb drainage, donate drainage, or or retain drainage. There's a excitement going on at my house. So the transparent film dressings, I don't use these very much. I use them if there's like thick eschar and it needs to soften. I put it on. So these are some of the etiological considerations and causes I'm about to get into. Lower extremity artery disease. Some other ones I don't touch on are, moisture associated skin damage, incontinence associated dermatitis, medical device associated skin damage. So you have to mitigate all those things. So lower extremity artery disease is basically reduced perfusion, and you can see the black cap that's typical. You don't want to disturb that eschar. Eschar is just like another word for scab. It's a slough that's been, what's the word? Totally, all the moisture is pulled out of it. And they'll be at risk if that gets disturbed, that it won't heal, and they'll be at risk for gangrene and osteomyelitis infection. Keep it warm, because being cold constricts the blood vessels. For the love, do not use external heating devices. And then we really pad these feet. Typically the wounds occur in the heels and ankles, sometimes toes. You pad it with lots and lots of gauze. Lower extremity venous disease, I see a lot of this. So this brown discoloration on the ankle is called hemosiderin staining, or hemosiderosis is the condition. And it's from, basically you get increased venous pressure, hypertension, and then it leaks out literal red blood cells between the cells of the venous wall, and you get blood in the tissues, you get tissue hypertension. And when those red blood cells die, their hemoglobin remains and the iron stains the skin brown. And so typically that wound's a classic presentation. The venous ulcers will look ragged, shallow, irregularly shaped. They drain highly, and they're typically in the quote unquote gator area of the ankle and upper foot. These can be challenging. They need compression, but that's the only way they're going to heal is with compression. So pressure ulcers, pretty much all nurses are familiar with these from our clinicals. This map shows common areas. So some things, it's a common thing I get consulted on. I literally tape in the patient's room education for both the patients and the nurses and the aides. When not eating, the head of the bed should not be above 30 degrees if they're a super high risk, just period. I don't want to see it. Not that I have that much authority, but I don't want to see it. Always float the heels, turn often. I post a turning schedule and post it on the wall so the patient can see it and remind themselves. And then sitting in a chair, jerry chairs cause injuries a lot. People think that they're good to just sit and not move. They still need to do repositions as if they were in a wheelchair. Neuropathic foot disease. So this is just, if you're diabetic and you get diabetic ulcers, neuropathic ulcers, it starts with debridement, with calluses. So the calluses, they're fine when they're supple and leathery like a bodybuilder's, but when they become hard as a rock, like a rhino horn, then basically it becomes a pressure injury, right? You can't walk on a rock and expect your foot to do well. They can also, not just from calluses, but also bony prominences. So with diabetes, I'm getting to the weeds a little bit here, but when people say they have neuropathy, typically what they mean is they have reduced sensation, and but neuropathy just means damage to nerves, and there's different kinds of nerves, so there's different kinds of neuropathy. So there's sensory neuropathy, there's pain neuropathy, which is the worst one. It's just constant shooting pain. Sometimes it's intermittent, like it varies by person. Motor neuropathy, the nerves that tell the muscles to contract, and when those get damaged, the muscles atrophy. They don't, they don't die, but they atrophy, and it can cause changes to the foot structure. And autonomic neuropathy, which is the sebaceous and sweat glands. So your foot gets extra dry, and dry feet are miracle grow for calluses. So if you have a diabetic ulcer, you have to reduce weight bearing, and the calluses need serial debridement. You need fitted for appropriate shoes, custom insoles with a shoe that's tall and wide enough, and with a soft shell that won't cause corns and calluses. So that's pretty much it. Thank you for listening, and wound care has been very rewarding for me. You guys have any questions?
Yeah, but thank you.
Thank you, Joe.
You're welcome.
I think Donna's hand went up. Donna, I'm sorry.
Donna, go ahead.
Yeah, Joe, thank you so much. It's been a long time since I've heard this kind of presentation. One question I have that I just saw anecdotally when I was working was fungal foot disease. Do you see a lot of that in your practice?
Do you mean like a skin infection or a nail infection?
Both.
So I see a ton of it, like when I'm not doing one of my mini collateral duties. About half of my consults are debridement of mycotic, which is fungal infected toenails, and diabetic foot screens with a monofilament. And so, I mean, I would say over probably 3/4 of the toenails I debride and trim have mycotic changes from dermaphysites, I believe they're called, living in the space between the nail, and it changes how they grow. They can get thick, and if they don't have a soft shoe, the nail can get so thick and tall that it actually causes a pressure injury as it presses on, like an institutional steel-toed boot, for example. So yeah, I do a lot of that. And as far as treatment, there's the oral medication that's non-formulary where I work, and it is hard on the liver. They need to do serial chemistry to check the liver enzymes. It doesn't get approved very often. So they just see me and I debride the toenails. If there's just discoloration, like yellow discoloration, you can try antifungal ointment around the cuticle once or twice a day for months, because the toenails grow so slowly, and that ensures like the matrix is healthy, and so the new nail that grows in pushes out the old infected nail. It doesn't always work, especially if it's thick, but it's worth a try. The difference in the medication concentration at the matrix between the using an ointment and taking a pill is like 50 fold. Like the pill at the target site is 50% more concentrated than just using the topical Lamisil or Tolmafdate or whatever.
Joe, I have a question. Like one of the wounds, the pictures that you showed, you talked a little bit about like the eschar. How often do you have to have surgical debridement to be able for wound healing? Or like, will that eventually slough off without intervention?
So when you have an arterial ulcer with eschar like that, it's never going to heal until they see a vascular surgeon and get reperfusion. That may just be a stent, or it could be like a bypass or something. But as a consultant, my goal for an arterial ulcer, especially like a textbook one that has a black eschar like that, the goal is not healing. The goal is stabilization. If that wound gets no worse, I'll have done my job, and the nurses will have done their job. It's when the nurses that like to pop pimples start picking at it.
Yeah.
When things go south. But to answer your question, for not arterial ulcers, surgical debridement, basically it's when the amount of dead tissue on the wound. Like if the wound devolves quickly, then you just kind of get like this devitalized, not rotten, but this devitalized tissue that's not coming back. It's dead and it's adhered and it's stuck. And I can debride wounds. I can remove slough, which is dead tissue. But when it's imagine like a big chunk of tissue that's just dead. Like I can't. That's kind of beyond my. I can remove devitalized tissue, but I can't just be like cutting slices off people.
Right.
They need to go to an OR room and get general anesthesia, and then they cut down until they remove all the dead tissue. So they cut down further than maybe you would suspect they need to go. They remove a lot, but that's so it can heal appropriately.
Yeah. So I guess if it's arterial, then you should just think of it like protective, but like a, it's kind of providing some protection. So don't pick it.
Yeah, pat it a lot, lots of gauze,
Yeah.
lots of Kerlix or rolled gauze, and keep it warm, keep it protected from injuries. Especially like rolling the patient and they knock into things. Just be careful with it.
Have
Right.
you used any larva therapy?
What is it? What kind?
Larva therapy?
I have not. I read about it and it works really well from what I've
Yeah.
seen.
We've had a few patients that had chronic wounds for many years, and it was amazing what that did. And it was relatively inexpensive, so I couldn't believe it. It was miraculous, really.
I would love to. That would be really fun for me.
Yeah.
Any other questions for Joe?
No, it was wonderful.
It was, thank you. Yes, I think it was good. It was a good review. Very good, Joe. Thank you.
Excellent.
I think good questions follow up as well. So,
Thank you guys.